Cardiology burst, part 3. Which test should you perform in a patient that has a pacemaker? A dipyridamole thallium scan or a stress thallium exercise test? A pacemaker patient you're about to stress. Do you get myocardial perfusion imaging or do you put them on a treadmill for an exercise stress? You get the nuclear stress in someone with a pacemaker. You don't want to put them on a treadmill. So why? Why don't you exercise stress pacemaker patients? So besides the fact that myocardial perfusion imaging is more sensitive and specific, besides that, there's another reason. It's because standard exercise stress tests, what they do is they look at ST segment changes. Now, in patients with pacemakers, this is often unreadable. The EKG morphology is not appropriate, and it's just impossible to read. So the bottom line, patients with pacemakers, you get a nuclear stress, do not get an exercise stress test. Next, what is the formula for systemic vascular resistance? Abbreviated SVR. So the formula for systemic vascular resistance is the mean arterial pressure minus the right atrial pressure, that difference divided by the cardiac output. So mean arterial pressure minus right atrial pressure, that difference, and you divide that by the cardiac output. And that gives you your systemic vascular resistance. But now tell me the units. So what units will that be in? So those are Wood's units, W-O-O-D as in dog, S. So how do you convert to dynes? So oftentimes we talk about SVR with the dynes units. So you simply multiply 80 to convert the Wood's units to dynes. Now your answer is in dynes times seconds, that product over centimeters to the fifth. Now what I find interesting about this is analogous to Ohm's law from physics. V equals IR. Voltage equals flow times resistance. So the mean arterial pressure minus the right atrial pressure is the corollary of voltage. And the cardiac output is the corollary of flow. And then your SVR is your resistance. So what I find interesting about this is we're taking an electronics principle and applying it to a pulsatile hydraulic system. And I find that to be, a bit interesting. All right, let's talk about elective surgery in patients with aortic aneurysms. So the indications for elective surgery are going to be based on either number 1, the size of the aortic aneurysm, or number 2, the rate of growth of the aortic aneurysm. All right, let's talk about ascending aortic aneurysms. So at what size should you perform elective surgery in a patient having an ascending aneurysm? What's the size cutoff? Ascending aneurysms, 5.5 centimeters. That's the cutoff for elective surgery in a patient with an ascending aneurysm. Now, what about a descending aortic aneurysm? 6.5. So 6.5 is the cutoff for elective surgery in a patient with a descending aneurysm. So these criteria, the ones I just mentioned, apply to patients without any family disorders such as Marfan syndrome. Now, patients with Marfan syndrome or familial aneurysms or other things, they should undergo early repair. So you're going to have a lower threshold for elective surgery. So when the ascending aorta grows to 5 centimeters or the descending aorta grows to 6 centimeters. So you subtract 0.5 centimeters from the aforementioned criteria. Now, what about the rate of growth for any aneurysm? So rate of growth, that's also important. So size or rate of growth. A rate of growth of a centimeter per year or faster is an indication for elective surgical repair. So let's summarize all this, okay? Number 1, an ascending aortic diameter greater than 5.5 or a descending aortic diameter greater than 6.5. Number 2, you subtract 0.5 centimeters from the cutoff measurements in the presence of Marfan syndrome, family history of aneurysm, connective tissue disorder, bicuspid valve, aortic stenosis, if they're undergoing other cardiac operations, and etc. Number 3, growth rate greater than a centimeter per year. And number 4, anything that's symptomatic. So a symptomatic aneurysm, ascending or descending, they should have surgery. Next, A 40-year-old male patient presents with a finding of symptomatic congenital pulmonary valve stenosis. What is your play on this? So 40-year-old male, congenital pulmonary valve stenosis, it's now symptomatic. So how are you going to deal with this? So this is a pulmonary balloon valvuloplasty. Okay, pulmonary balloon valvuloplasty. You don't necessarily have to replace the pulmonic valve, you do valvuloplasty. All right. A patient with asymptomatic severe aortic stenosis arrives in your hospital with a broken hip. Does this person need aortic valve replacement prior to undergoing hip surgery? So the patient has severe but asymptomatic aortic stenosis. So this is defined by either a valve area less than 1 centimeter square or a valve gradient greater than 40 millimeters of mercury. So does this person need an AVR prior to undergoing hip surgery? No. If a person has severe aortic stenosis but they're asymptomatic, you send them directly for hip surgery. So you don't need to replace the aortic valve just yet. Now, a patient with asymptomatic severe aortic stenosis who is in your hospital for a CABG, that's different. So this person should have aortic valve replacement at the time of CABG, and that is a class 1 recommendation. Using the Fick principle, what is the general formula in determining cardiac output? So applying the Fick principle, the general formula for cardiac output is cardiac output equals oxygen consumption divided by the arterial venous oxygen difference. So this is very general in the sense that we're not applying the constants or the numbers here. But the general formula applying the Fick principle is cardiac output equals oxygen consumption divided by the arterial venous oxygen difference. Next, after diagnosing a right ventricular MI in a patient who has severe chest pain and a blood pressure of 88/58, what should you do first? So right ventricular MI, severe substernal chest pain, and a blood pressure of 88/58. Do you want to, number 1, give sublingual nitroglycerin, or number 2, give a liter of normal saline? Right ventricular MI, severe chest pressure, and a blood pressure of 88/58. Nitro or fluids, you give a liter of normal saline. So nitroglycerin is totally inappropriate here because, number 1, the patient has a blood pressure less than 90. So you never give nitroglycerin if the blood pressure is less than 90. But also, reason number 2, nitroglycerin is contraindicated in patients with right ventricular MIs because of the potential to cause venodilation and subsequent hypotension. So using nitroglycerin here would have been wrong on multiple levels. So the blood pressure less than 90, and simply the fact that this is a right ventricular MI, you're not going to use it anyways. So why the liter of normal saline? So RV infarcts, you get a reduced RV diastolic pressure and consequently a reduced preload in the left ventricle. So by increasing the pressure gradient from the right atrium to the left side of the heart, you can maintain filling pressures within the left ventricle. So if the hypotension is severe enough and a liter bolus doesn't help, you want to consider dobutamine or other inotropic agents. But always start with a liter of normal saline. All right, last. A tall R wave in V1 on the electrocardiogram. What can cause that? So you should know these, at least 3 of these. So tall R waves in V1. What could this be? So number 1, RVH, right ventricular hypertrophy. Number 2, a right bundle branch block. And number 3, posterior MIs. So those are the 3 that you really should know for causes of a tall R wave in V1. But there's a few others. Number 4, dextrocardia. Number 5, the dystrophies. So these are often forgotten about: Duchenne muscular dystrophy, etc. Number 6, hypertrophic cardiomyopathy. Number 7, Wolff-Parkinson-White type A. Number 8, incorrect placement of the leads. So for example, you mix up the precordial leads. And finally, number 9, normal variant. So especially in young children, young adults, you can have a tall R wave in V1. So real quick, number 1, RVH, number 2, R right bundle branch block, and number 3, posterior MI. 4 is dextrocardia, 5 is the dystrophies, number 6, hypertrophic cardiomyopathy, 7, Wolff-Parkinson-White type A, 8, incorrect lead placement, number 9, normal variant. So you should know some of those, if not all of them. So tall R waves in V1, they do come up quite often. So that's it. Thank you. So long and good luck.